Good morning. So welcome to the session. My name is Christina Chadwick, and I'm a pediatric gastroenterologist and clinical assistant professor at the University of Florida in Gainesville, Florida. And I will be co-moderating this session with Megan.
All right, good morning. 7:45 on a Saturday. Well done, everybody. My name is Megan Cook. I'm a dietitian at Children's Healthcare of Atlanta. And here is our session today. No disclaimers from the presenters. All right, so in the era of highly effective modulators, this session is going to take a look at the implications of the CFTR modulators from several perspectives. We're going to discuss the risks of pancreatitis while on CFTR modulators and the effect of the modulators on fecal elastase. Furthermore, we're going to look at the impacts of those modulators on the liver and nutritional implications on liver wellness. We will review the pathophysiology and mechanisms of pancreatitis within CF and the potential risk of pancreatitis while on CFTR modulators. We're going to examine liver implications and liver wellness within the current era of CF, especially with increasing and earlier CFTR modulator use. And we will evaluate the role of fecal elastase and its significance in the era of CFTR modulators.
Okay, so our first speaker today is Dr. Mega Mehta, and she is a pediatric gastroenterologist and clinical assistant professor at University of Texas Southwestern Medical Center in Dallas, Texas, and she is the director of the pediatric pancreas program there. Thank you.
All right, I want to thank the moderators for inviting me to give this talk, and I want to thank all of you for coming this morning to learn all about the CF pancreas. I have no disclosures relevant to this presentation. By the end of this talk, I hope you'll be able to appreciate the unique aspects of the exocrine pancreas phenotype and disease in persons with cystic fibrosis, and also understand the impact CFTR modular therapy may have on pancreas function and disease. First, let's discuss the manifestations of the exocrine pancreas and cystic fibrosis. CFTR channels are present in pancreatic ductal epithelium. They are responsible for the secretion of chloride and bicarbonate, which in turn drives fluid shifts into the pancreatic duct. This fluid is responsible for the transport of enzymes from the acinar cells into the duodenum, which help to digest or break down fat and protein nutrients. CFTR dysfunction would result in impaired chloride and bicarbonate secretion, which in turn results in lower pH pancreatic fluid, lower volume, and increased viscosity. And over time, this thickened pancreatic juice leads to ductal obstruction, inflammation, and acinar injury, which ultimately results in pancreatic pathology. So we know that the genotype of CFTR mutations matters. Specifically, class 1, 2, and 3 genotypes are associated with more severe pancreas phenotypes, including pancreatic insufficiency. There are modifiers, though, including epigenetics, genetic modifiers, environmental factors, and socioeconomic status that can all affect disease outcomes. One manifestation of pancreas pathology is exocrine pancreatic insufficiency. Here, in utero, CFTR dysfunction results in acinar damage, which can lead to near total loss of exocrine function. This results in maldigestion, which clinically presents as diarrhea or greasy stools, failure to thrive or malnutrition, and fat-soluble vitamin deficiency. This typically presents in infancy and affects up to 85% of persons with cystic fibrosis. Exocrine pancreatic insufficiency is usually indirectly diagnosed using fecal elastase, with less than 200 micrograms per gram considered to be abnormal or insufficient status. However, the gold standard for diagnosis is direct testing using CCK or secretin stimulation. This is typically done endoscopically, but because this is invasive, cumbersome, and expensive, it's rarely done. When diagnosed with insufficiency, it's managed with the use of pancreatic enzyme replacement therapy, or PERT. Another manifestation of pancreas pathology is CFTR-related pancreatitis. Here, CFTR channel dysfunction results in inappropriate backup of pancreatic juices and early activation of pancreatic enzymes, which drives inflammation in the pancreas that ultimately results in acute pancreatitis. When looking at all children with recurrent and chronic pancreatitis in the INSPIRE consortium, we found that 28% had a CFTR mutation. Typically, these patients had a single CFTR mutation without an underlying diagnosis of cystic fibrosis or CFTR-related disorder. How about when we look specifically at pancreatitis and cystic fibrosis persons? This seminal paper from Uwe et al. In 2011 looked at the study of pancreatic sufficient cystic fibrosis utilizing pancreatic insufficiency prevalence, or PIP scores, which is a surrogate measure of severity of specific CFTR mutations. They found a gradation of risk of pancreatitis according to the CFTR genotype. Specifically, genotypes associated with mild phenotype had a 2.4 times higher risk of pancreatitis compared to genotypes associated with moderate severe phenotypes. And this group also had an earlier onset of acute pancreatitis. They theorized a model for risk of acute pancreatitis, surmising a critical threshold between balance of acinar cell function and ductal obstruction, as seen on the figure on the right, where essentially there must be some degree of preserved acinar function, along with some degree of ductal obstruction in order for pancreatitis to occur. In other words, milder CF mutations, typically pancreatic sufficient cystic fibrosis, has a higher risk of pancreatitis. Of note, modifying factors exist, including smoking and alcohol use, which can increase the risk for pancreatitis. It should be noted that a cohort of CF and CFTR-related disorder patients exist who present with pancreatitis first. In a retrospective review published by Dr. Chadwick, 18 patients across 2 centers were identified with recurrent or chronic pancreatitis as the initial presentation for CF or CFTR-related disorder. 72% were diagnosed with cystic fibrosis based on elevated sweats greater than 60 or intermediate sweats with 2 pathogenic mutations, and 28% were diagnosed with CFTR-related disorder based on intermediate sweats with 0 to 1 pathogenic mutations. Notably, half of these patients had concurrent manifestations of CF, including sinusitis, polyps, recurrent pneumonia, or gallbladder disease, and nearly half were pancreatic insufficient at time of diagnosis. 1/3 were eligible for potentiator therapy at the time of its publication. Likely this number would be higher since then indications for modulator therapy have expanded. I suspect we will continue to diagnose more patients with a late diagnosis of cystic fibrosis or CFTR-related disorder as genetic testing in pediatric recurrent and chronic pancreatitis increases. The last manifestation of pancreas pathology is pancreatic cancer. We know that persons with cystic fibrosis have a 5 to 10 times higher risk of pancreatic cancer compared to the general population. This risk is likely multifactorial. Chronic inflammation due to pancreatic duct obstruction, bile duct abnormalities with impaired bile flow, and dysbiosis all can play a role. There are also CF-related genetic factors that are associated with pancreatic cancer susceptibility, which can affect immune response, cellular metabolism, and other pathways for pancreatic carcinogenesis. It should be noted that as life expectancy for persons with cystic fibrosis increases, cancer prevalence will also likely increase. This is an evolving field of study with more research needed to better understand this cancer risk. Next, let's discuss the effects modular therapy may have on CS pancreas pathology. There are several studies that show improvement in fecal elastase with modulator use. Arrival, which studied ivacaftor use in 12 to 24-month-olds, as well as Kiwi, which studied ivacaftor in 2 to 5-year-olds, and its open-label 84-week extension study CLIMB, found a mean absolute increase in fecal elastase ranging from 99 to 164 micrograms per gram. In a scoping review, Ramsey et al. Found the aggregate mean absolute change in fecal elastase improved by 190 with a sample size of 34, of which 21% converted to pancreatic sufficient during the treatment course. And certainly there are other examples that suggest some degree of improved exocrine function as evidenced by improvements in BMI and other GI symptomatology such as steatorrhea, bloating, and gas. On the flip side, there is also data that suggests that there is no significant improvement. In the PROMISE trial, which studied children greater than 12 years old on ETI therapy, there is no significant change in fecal elastase values after 6 months of therapy. Persons with CF with prior modulator use were found to have a higher baseline fecal elastase value, but this subgroup also had no significant change in their fecal elastase values after 6 months of ETI. This begs to question, is there a window of opportunity with early modulator use? Kimberly Stevenson will be speaking after me, and she'll be sharing results of her study. So I don't want to steal her thunder, but suffice to say they found age negatively correlated with change in fecal elastase values. And we know there are positive effects in utero with modulator use. There have been multiple presentations during this conference discussing the possible benefit of maternal antenatal modulator use to mitigate meconium ileus. Fortner published a case report of a child with F508 homozygous mutation born to mother with cystic fibrosis on highly effective modulator, who was born pancreatic sufficient and had normal growth parameters early in infancy. And we also know from ferret models that in utero and sustained postnatal ivacaftor exposure improved fecal elastase and growth, but withdrawal of ivacaftor saw a return of a pancreatic insufficient state. This suggests that early use of modular therapy is more beneficial than initiation later in life, when perhaps there is decreased possibility of acinar cell function recovery. What about the effect modulars may have on risk of pancreatitis? Many case reports have been published showing occurrence of acute pancreatitis after starting modulator therapy. Gould et al. Found 5 cases of pancreatic insufficient cystic fibrosis patients across 3 Canadian centers who developed acute pancreatitis after starting CFTR modulators with a median duration of 30 months of modulator therapy. Notably, 3 had developed some exocrine function with fecal elastase values greater than 100. Redman, Patroclo, and Megala all published examples of pancreatic insufficient persons with cystic fibrosis who developed acute pancreatitis after use of modulator therapy. And Sanders et al. Published a case series of 2 patients with acute pancreatitis after starting ETI therapy. But notably, these patients had no issues when treated with ivacaftor alone for 5 years. But there are also many case series and studies demonstrating decreasing rates of pancreatitis on modulator therapy. In this scoping review by Ramsey et al., 27 subjects were found across 8 studies, totaling 133 patient years of follow-up data. They found overall improvement in number of acute pancreatitis episodes with modular therapy, as shown in the figure on the right. To break it down, they found an 85% risk reduction in incidence of acute pancreatitis from 0.73 per patient year down to 0.11 per patient year with modulator use. When looking specifically at pancreatic sufficient cystic fibrosis, they found an 87% risk reduction. Notably, all episodes of pancreatitis on modular therapy in this group occurred in 1 person during periods of ivacaftor noncompliance, so perhaps the actual risk reduction could be even higher. In another study of a sub-analysis of INSPIRE-2, which is an international consortium studying recurrent and chronic pancreatitis in children, 22 patients with 1 or more CFTR variants on modular therapy were identified. The pancreatitis per total person time incidence density decreased by about 40% with modulator use. The graph on the right neatly visualizes the change in acute pancreatitis frequency in this cohort, with the left-hand side showing frequency of pancreatitis attacks in the 2 years preceding initiation of modulator therapy, and the right-hand side showing decreased frequency after starting therapy. Dr. Ginsberg gave a beautiful presentation on these findings earlier in this conference, and you can also learn more by visiting poster 601. Finally, in a paper by Ramsey et al., a large healthcare database called MarketScan was queried over a 6-year period, identifying 10,417 persons with CF, of which 1,795 had some CFTR modulator exposure. They defined pancreatic insufficient cystic fibrosis by use of PERT therapy in the preceding 12 months and defined CFTR modulator therapy by filled prescriptions. Subjects were defined as off therapy if modulators were not prescribed or filled for 60 days. Unsurprisingly, the study found pancreatitis was more common in pancreatic sufficient cystic fibrosis at 2.9% versus 0.9% in insufficient CF. Interestingly, the study found a 64% relative risk reduction of acute pancreatitis in pancreatic sufficient cystic fibrosis, but also a 47% reduction in pancreatic insufficient cystic fibrosis with modulator use. When looking at estimated pancreatitis rates per 1,000 patient years, there was improvement from 12.93 down to 4.65 episodes of pancreatitis per 1,000 years with modulator use in pancreatic sufficient cystic fibrosis. Now, we know the incidence of acute pancreatitis is low to begin with in pancreatic insufficient CF, but even here they saw an improvement from 0.67 down to 0.34 per 1,000 years with modulator use. So to summarize, there are case reports of pancreatitis occurring with modulator use, and also quite a few larger case series showing improvement in pancreatitis frequency with modulator use. And this probably makes sense when we look back at this model of CFTR function and risk of pancreatitis. If modulators have some positive effect on acinar function and ductal obstruction, then you will likely move the needle on this graph with modulator use, where you might see a rare pancreatitis episode develop in a pancreatic insufficient person with cystic fibrosis who is regaining just a little bit of cell function. But on the flip side, you will likely see a much larger protective benefit in a person with pancreatic sufficient cystic fibrosis who has even more robust improvement in their acinar cell function. So in the future, we still have many questions that need answering. We need to understand when and how often we need to check for return of exocrine pancreatic function and understand what the implications are for PERT utilization. We also need clear risk stratification for acute pancreatitis with use of modulator therapy. Here, a prospective study would be beneficial. Lastly, we need to learn if modulators may mitigate the risk for pancreatic cancer. In conclusion, cystic fibrosis can impair exocrine pancreatic function, resulting in pancreatic insufficiency, risk of pancreatitis, and pancreatic cancer. Modulator use may improve exocrine pancreatic function. The data suggests this effect is more robust with early utilization of modulators. Modulators have been shown to both increase and decrease frequency of pancreatitis, likely related to the effects of modulator use on exocrine function, as well as the baseline CFTR pancreas phenotype of the patient, i.e. if they're pancreatic insufficient or pancreatic sufficient. Nevertheless, the incidence of pancreatitis is overall low, and larger retrospective studies suggest that there is an overall protective effect. In the era of precision medicine, we need to consider the pancreas phenotype of the modulator-eligible patient in front of us in order to develop patient-centered treatment outcomes, goals, and monitoring. And with that, I would thank you, and are we taking questions now?
Mm-hmm. Thank you. Thank you. Any questions?
Good morning. Thank you for the great presentation. I'm Ella from UCSF, GI fellow. Is the pancreatitis definition in CF people the same? Like, do we expect the lipase to be 3 times upper limit of normal, and we expect similar imaging findings?
Yeah, that's a great question, and honestly one that hasn't been explored entirely. We still use the traditional definition for pancreatitis, which is based on both adult Atlanta 2 and Inspire criteria, which requires 2 or more of the 3 following criteria, which is lipase or amylase greater than 3 times the upper limit of normal, pain or typical symptoms of pancreatitis, and or imaging findings of pancreatitis. It's possible that with cystic fibrosis, where you have likely insufficient pancreas function, that maybe you may not mount as robust of an enzyme response or see the typical findings on imaging. But we really haven't studied it well enough to change the definition in these patients.
Did all these studies that report pancreatitis use the same definition?
Correct.
Okay.
Yep.
Thank you.
All right, any other questions? Okay, thank you so much. Thanks.
Oh, sorry. Question.
Oh, sorry.
Hi, sorry. My name's Linda Cummings, and I'm a gastroenterologist seeing adult patients. And I would just say that in the adult patients, oftentimes we don't see any elevation in lipase, so it's really based on CT imaging. I was just going to ask if there was a way to study this prospectively in which patients were ever randomized, or do you think there's not equipoise to do something like that?
I missed the last part. Is randomized to use of modulators?
Randomized to modulator use versus not, in terms of looking at acute pancreatitis, or basically we have so much data showing in a given patient that pancreatitis episodes seem to decrease in the patients who were at risk for pancreatitis before they were on modulators, but in terms of study design, sometimes randomized trials are more robust, but I don't know that there's any great way to do that in this population.
Yeah, I think that's a great question. I agree with your first point. We certainly see that in patients with chronic pancreatitis where they may not see the serum elevations, but we maintain a lower threshold to get imaging of the pancreas to diagnose pancreatitis attacks in these patients. To the second part, I think it would be difficult to do a randomized control trial in persons with CF, but maybe another avenue would be looking at people with recurrent chronic pancreatitis who have a CFTR mutation that may be eligible for modulator therapy, because these patients typically have a higher disease burden of pancreatitis, so it would be a little bit easier to study if there's improvement in their disease burden with use of modulator therapy. So maybe segueing into that population instead might answer the question better.
Okay, thank you. All right. I would like to bring up Kim Stevenson. She's a registered dietitian at the University of North Carolina Hospitals in Chapel Hill, and where she has worked with children and adults with cystic fibrosis for the last 26 years.
Good morning, and thank you for the time to discuss this topic. I have no relationships to disclose for this presentation. So what I'd like to share today is our publication from last year on elastase changes in children on modulators. This is what we believe to be the first set of real-world data where we looked retrospectively at children on modulators and their elastase changes. We combined our data with 3 pediatric centers, UNC Chapel Hill, Children's Mercy in Kansas City, Missouri, and Children's Hospital of Georgia in Augusta. I'd like to take you through both how this project evolved at our center at UNC and how, and also the data we pulled retrospectively. So the who, what, when, where, and why. Children with CF who are taking modulators or on PERT, we wanted to recheck their elastase, which is, as Dr. Mehta mentioned, an indirect measure for exocrine pancreatic status. We tested them after they'd been on a modulator, either at home or in our clinic and across these 3 centers. And the why is the really important part, and the part that drives me is that if they're able to discontinue PERT, that is a big deal. It's a big deal to have that conversation with families and reduce medication burden. And it's really interesting as a dietitian to know that their absorption and digestion has really changed. So this started at our center, where all great ideas come from, I do believe. A parent asked a question. They asked us, could my child, who was with her, with the parent, who's 12 years old, could she have improvement in her pancreatic status? Now, this child had started her modulator earlier at 6 years old. So we all discussed it and thought, well, we don't know. Certainly there's a possibility. Let's check it. So we checked her elastase. It was the first one at our center. She had become pancreatic sufficient with a value over 200 and came off of her enzymes. We subsequently found 4 other children at our center, either through a parent asking or provider asking that question. And then we said, okay, wait, we're probably missing some other kids here. So we really need a systematic method to test these children and their elastase values. So we reviewed the literature, and this was really a team approach between our nutritionists, who are really interested in digestion and absorption, our pharmacists, who are really interested in all the benefits of modulators, and our nurses, pulmonologists, and gastroenterologists who are interested in all of that too. And then we shared it with other CF centers. We said, hey, we're trying this out. Maybe you would like to do it too. So this table has the changes in elastase that we know of, some of which Dr. Mehta already went through for ivacaftor, lumacaftor, ivacaftor in the peach area, and ETI in the purple area at the bottom. But if you'll follow with me to the column at the far right in blue, that's a summary of all of this. So this is what we knew at the time when we tried to create our clinical guideline for our center. The first one is that the elastase increased by anywhere from 39 to 299 points on modulator. Anywhere from 6% to 67% who were tested converted from pancreatic insufficient to pancreatic sufficient with a value greater than 200 on elastase. The age at which a modulator was started spanned anywhere from in utero all the way up to 7 years old. But importantly, as has already been pointed out, in the PROMISE GI study, children over 12 did not show a significant improvement. And the time that they had been on their modulator when tested was anywhere from 1 month all the way up to 7 years later. But the most common was that 6-month mark done in our clinical trials. So this is our guideline that we created at UNC. I don't expect you to be able to read it all, but here it is. And if you would like to see this, happy to share it. The algorithm within this document, on the far left, you can see that if their elastase came back greater than 200, we had a plan to discuss weaning their PERT or enzyme therapy, and then continuing to monitor them at least yearly to make sure they stayed within that category. And then if they were still less than 200, we also had the opportunity to recheck them again every 6 to 12 months or as decided by providers. So for stopping PERT at UNC, we decided to wean a little bit slowly. We did half the dose for a couple weeks, had the parents monitor for steatorrhea or any other GI symptoms, and then took them off. While some of the other centers just stopped the PERT completely, and that worked also. For this study, we only collected data on whether they stopped their vitamin or not, but our guideline at UNC, we did have a plan to, at the visit following stopping their PERT, we'd check their vitamin levels, and if they're normal, then go ahead and take them off the vitamin, CF vitamin. So this is what the kit looks like that we provided to patients in clinic, our stool kit. It has a hat, 2 bags, we got a double bag so we don't have to smell it, and the sample vial for parents to use. And we just were trying to make it easier for parents to do this collection either at home or in clinic. These are the instructions we provided. We call it stool tools, and it has an excellent amount of potty humor in it to go along with the study. It helps with children and with teenagers. So what was happening at these 3 centers is that we were offering elastase testing to children with CF who are on any modulator and any PERT therapy, even though the guidelines differed slightly at each center. They were on modulator for at least 6 months, and then they were either less than 12 years old at the time of testing or less than 12 years old when they started their first modulator. But we also had this caveat that we could offer this to any child at any point who happened to show some symptoms of possible pancreatic sufficiency. Either they had pancreatitis or they were skipping their enzymes with no GI or steatorrhea symptoms. And then for collection, as I said, at UNC, we provided the kit. Some places the lab provided the kit. This was done either in home or in clinic. Usually the ones in clinic were mostly the babies who had diapers and they're easy to collect. And then labs we were using was Mayo, LabCorp for parents to be able to go locally and provide the stool and not have to wait till they came back to clinic and bring it back to clinic with them. And then the Children's Hospital of Georgia had their own internal lab that measures elastase. This made for ease of return. They could bring it to any local lab or back to the center. There were slightly differing requirements, but they were all testing for human elastase using the monoclonal antibody. So what did we find? We had a total of 70 children across the 3 centers. 53 of these had a baseline elastase available to us. We didn't require that they have it for the study, but we knew that 53 did, usually from birth or diagnosis, but any time before modulator was started. 15 of those 17 had a value of pancreatic insufficiency after modulator, so we can assume that even though we didn't have a baseline, they probably had a value prior to modulator. And 2 of them who did not have a baseline also had a genotype associated with PI. So 129 was the average or mean of their post-modulator elastase. About 78% were on ETI, although we had children on all modulators that are available in the US. 40 months was the average time from start of their modulator to this check of elastase. And that was a long time, but we had a lot of children who had been on modulator for years and were just now starting to check elastase. And then 7 years is the average age at which they started their first modulator. So for our general results, for those who had able to compare baseline and post-modulator value, the mean absolute change or improvement was 93 points. Figure A shows that elastase was significantly higher post-modulator than pre. And figure B shows a negative or inverse correlation between age and change in elastase or their improvement in elastase, so that younger ages had greater increases across our group. We did not find anything significant for time on modulator, so it wasn't that the longer you were on it, the more change you had. That did not hold true for our population. So we had this subgroup of children who did become pancreatic sufficient while on their modulator with a value greater than 200, so 15 of 70 or 21%. So we looked into what we know about that group of pancreatic sufficient patients. 13 of the 15 did stop their PERT. One had a reduced dose, and they had planned to recheck elastase again to confirm. And then one did not change PERT, but there was this plan to outgrow the dose. And of the 13 that stopped their PERT or enzyme therapy, 10 also stopped their CF vitamin. So this is our list of 15 patients who were pancreatic sufficient. And I just want to pause for a second and think about this opportunity we had 15 times to talk with the family about stopping enzymes. It's a wonderful, exciting, and inspiring conversation for me. I did not know that we would get to have these conversations during my time with CF, and it's exciting. We had them on all of the modulators available, all 4. The age at which they had started modulator, we had them as young as the 4 months and as old as almost 9 years old. And then the time at which they had their the age at which they had their elastase test was around 1.5 years was our youngest, and 13 our oldest. So what else do we know about this subgroup of our pancreatic sufficient patients, this group of 15? Figure 2A shows that the pancreatic sufficient group had a lower average age of initiation of their first modulator, so they were younger. And figure B shows that the pancreatic sufficient group had a higher baseline elastase, so before starting a modulator. Outside of that group of children who were pancreatic sufficient, we looked at those who had more than one elastase value while on modulator. So we had 10 of these children who either over time had more tests done, either somewhere from 2 to 7 tests each. 80% of them stayed within that category. If they improved to PS, they stayed there. If they were pancreatic insufficient before and after, they stayed there. But 2 of the 10, or 20%, had inconsistent values. They had one value that improved above that 200 microgram cutoff and one that was then subsequently below. Neither of these 2 children stopped their PERT therapy. It didn't seem to fit, the value of elastase didn't seem to fit with their clinical picture. They had lower weight gain, abdominal pain, and some other symptoms. So we looked at this, the elastase test. The elastase test is really good at diagnosing severe PI. That's what it was, standardized for, to diagnose children with PI. So it's really good in those lower numbers. The variability is low, the sensitivity is high. But as those numbers increase for elastase, you get more variability and less sensitivity. So we found that we had to begin to use more caution when children were in those higher values or around that 200 microgram cutoff. We sometimes would say, let's get a second. Let's just make sure before we make any clinical change. And we also wanted to look at, does this elastase value fit with their clinical picture? So in summary, we had 70 children across 3 pediatric centers, 53 of which had a baseline. We had a significant increase in their elastase value. Their mean absolute change was around 93 micrograms per gram. The younger ages had a greater increase in elastase. We found 21% of the children with the test were pancreatic sufficient with a value greater than 200. And that group of PS patients were younger at the start of their first modulator and had a higher baseline elastase. So other things that we learned, Our elastase improvement was similar to IVA and LUM-IVA studies, but was greater than what's currently published on ETI. The ideal time to retest their elastase, we still don't know. And including children on all modulator therapies seems to be important, and in particularly those who are younger or who perhaps have a higher baseline. And multiple tests of elastase may be important, especially with those who have values closer to that cutoff. These are my references. And then I'd like you to look at the lower list on this slide of all the people who are involved in this study: our nutritionist, our pharmacist, pulmonologist, gastroenterologist, a whole group working together to make changes for these children. And I'd also like to point your attention to the numerous posters this year who are of other centers also rechecking elastase. Please go check out their results.
Thank you. Great. Thank you. All right.
All right, do we have any questions?
Hello. Tom Safara from Rainbow Babies and Children's in Cleveland. I just wanted to make a question and comment. Even with the posters that you show, there's this wide variability of patients who are on modulator therapy. Centers show wide range of differences. Any idea why that's happening, or any effort to really make a much larger study to look at this, especially in light of the promised data that came out to show there's really no change in elastase levels?
I will take a jab at it that I think it depends on some of this elastase data are just looking at ETI. Some are looking at all modulators. Some are looking at all ages. Some are targeting children less than 12. So I think maybe it just depends on the population, of course, sample size, and which modulators you're looking at. But I think, of course, we don't know for sure, and a larger study would be fantastic. Maybe I should get all these posters together and we'll make it happen.
Okay. I'll take the next question.
That was an awesome and exciting talk. I'm Sarah from Vanderbilt, so not too far away from you guys. So I think like what we're seeing at our center, because we've definitely have some kids convert from insufficient to sufficient on Trikafta, and it's so exciting. But I think what we're struggling with is like, how do you know when to stop enzymes cold turkey versus do more of a taper? So I was just curious, like for your patients, like did you use any kind of specific fecal elastase marker to know as to stopping versus weaning? And then for the patients that you did wean, could you talk a little bit more about how your process for tapering off?
We did not have a specific value except that 200 mark. If they were well above it or well below it, we felt comfortable to take them off their enzymes. As far as doing the weaning, we'd had a couple of patients before we started this process who had needed to come off enzymes, and it just seemed more reasonable to go slowly. It's not based on any evidence, maybe just experience. But what I found is that most everyone, we drop them to half dose, everything's fine, and we just take them off. But we've had two recently that we dropped to half dose and did have a lot of changes in the amount of medication they need for constipation, so titrating a Miralax dose. So we kind of keep that in mind for children who had severe constipation prior to their modulator or at the beginning of modulator dosing, just to make sure that we kind of control everything as we take those enzymes away. But I don't believe we've had anyone with frank symptoms of steatorrhea when we went to half the dose. But at UNC, we do 50% dose for 1 to 2 weeks. We call the family back and ask how things are going. And if it's great, we just say you can stop.
Did the constipation get worse for some of those patients?
It did. Well, the parents reported changes in stool that were consistent with their pattern of constipation. We increased the Miralax and that resolved. And then we could move on with stopping the enzymes.
And so then you just continue to monitor growth and clinical symptoms.
Correct. Clinical symptoms. And we are rechecking their elastase yearly once we take them off enzymes, or more frequently if needed.
Thank you.
Yeah. You're welcome.
You answered my question.
So one of the early studies on this topic of regaining sufficiency was called Time for a Gut Check. And the first author maybe I'm saying this wrong, Megala was the last name. And they sort of suggested that the transition from pancreas insufficiency to sufficiency is often heralded with acute pancreatitis. Did you see any acute pancreatitis in your population?
We did not in this group of 70.
So, perfect, super helpful, thank you.
Hi, Jill Sullivan from the University of Vermont. I just wanted to point out that in the next large group, BEGIN, which is a multi-center prospective study of young children on highly effective modulator therapy, is presenting elastase values. So this is a large multi-center prospective. So come to that and hear the elastase data there too.
All right, thank you.
Can't wait.
I have two questions. Jade, University of Rochester. My first question was, did you track any data related to like growth percentiles with these 70 patients? Like, I know you said the data showed that like with elastase trends, if they had a higher baseline elastase, it showed that they were more likely to have like the regain of functioning. Was it patients who already had like a higher growth rate that had a more likely return of function?
We did not track growth for this study, but I believe from yesterday's poster session that Rainbow Babies did. Is that correct? Anybody here from that group? Vermont tracked. Look at Vermont's poster.
Okay. And then my second question is, another thing that I've been seeing clinically is people who have not a return of function, but like are still testing pancreatic insufficient, but maybe don't have clinical symptoms anymore. So they feel that they don't need enzymes, but are showing that they are still insufficient. Was there any of these 70 people who like were showing no clinical symptoms, but were still testing insufficient?
Well, we did not collect clinical symptoms as part of our study. So I can't speak to that for the patients who remain pancreatic insufficient. But I know from our center, from talking with people from other center, we certainly have people who feel just as well off of their enzymes, even though they may or may not have an elastase value, or perhaps they even have elastase value that's still low. I think there's probably could have some discussion on what is the optimal cutoff for elastase. Is it 200? Is it 100? Do you need are there some in that PI category that are in the high 100s that could reduce their dose? Maybe they don't need as much as they needed prior. So I think those are all interesting topics, and I think it would be a one-on-one case at that point to sit down with your team and the family and say, this is where we are, what do we want to try? I do have one patient I'm trying to get an elastase on because growth is normal on ETI, absolutely great, but his fat-soluble vitamin levels are nothing. He's completely low, completely pan deficient for fat-soluble vitamins, so I would assume he's malabsorbing fat. But for him, he doesn't want to restart enzymes, so our goal has been to restart his vitamin to try to get those levels up, even in the face of probable malabsorption.
Thank you.
I'm Sarah J. Schwarzenberg from Minnesota, and this is Jay Freeman from Nationwide. I really know that. I just want to remind people that symptoms are not a marker of pancreatic sufficiency. We have known this historically for 40 years, that you cannot determine whether somebody is pancreatic sufficient or insufficient by symptoms alone. Many people have no symptoms when they have no pancreatic function. Years ago, in the 90s, we had to take hundreds of people with CF off of their enzymes in order to test to see whether enzymes worked to get FDA approval for pancreatic enzymes. Huge percentages of those people had no symptoms whatsoever. So, yeah, I can't run a microphone. So I would caution you that there's a great desire to take away medications, and it makes us feel good to be able to say no medications. You're doing this scientifically. You're doing a fecal elastase. I'm all for that, okay? But I do believe you should follow the fecal elastase yearly because who knows what's going to happen in the future. But Doing this by symptoms, I think, is really not good to our patients. Perhaps they're not having nasty, foamy stools, but they're losing protein, they're losing vitamins, they're losing zinc, they're losing minerals, and someday that's going to come back in the form of malnutrition, the slow progression of malnutrition. So congratulations to you, great study, but let's use science to withdraw medications, okay?
I'm Senthil Sankaraman from Rainbow Babies. I briefly give a couple of comments. So I totally agree with Dr. Schwarzenberg. The caveat here is fat can cause constipation with slow GI motility, or it can cause steatorrhea, loose stools with fast motility, depending upon patients' underlying dysmotility, dysbiosis of diet pattern, things like that. And then in our study, we got really 6% because we just checked only ETI. And then we added a few more patients after we submitted the abstract. So we kind of closer to 9%, like 7 patients who are converters, 28 patients who are not converters. When we kind of like saw all the demographic and clinical parameters between the groups, converters and non-converters, the only thing which was standing out was their baseline BMI. If the BMI is higher, like 80th percentile median versus 50th, that kind of a marker, no age, genotype, or IRT, sweat test, FEV1, other parameters were all kind of equal between the groups. Thank you.
Thank you.
Hi, Kim Altman, the dietitian from the Adult CF Center in Columbia. So just to follow up on Senthil and Dr. Schwarzenberg, I agree. I have had plenty of patients stop enzymes on their own in my adult center. We are not following fecal elastase in our adults for the most part because it's not common for the adults to convert as much. So if I have a patient come in telling me that they have stopped their enzymes, most of them are genetically, they're not going to change. So most of them, we make them either restart, well, we can't make them, but we request that they either restart or we check a fecal elastase. Some of them will check the fecal elastase and restart, or they don't want to check the fecal elastase and they will just restart their enzymes. We've only really had one patient that declined to either restart or check a fecal elastase. She just felt like for her, she just didn't feel like it was necessary. So I do agree, like you do need the information, and if you give your patients the information that it is not just the symptoms that is, reflective of malabsorption, they're willing to listen for the most part and do the extra work to find out, can I stop this medication? So.
Excellent. And I would agree. I was surprised at how easy it was to get a stool sample from so many children. We really thought that would be a barrier. It is a barrier, I think, more for those over 12, which we were not focused on. The teenagers are not as likely to bring you some poop, but that can be a barrier to being able to know this. Thank you.
Okay, and thank you. We know that there's questions in the app, but just in the sake of time, we wanted to go ahead and move forward. So I believe that the speakers are able to look at those questions, and maybe Kim can take a look at those. Thank you. All right. I would like to bring up Dr. Jay Freeman. He is a professor of pediatrics at The Ohio State University, where he serves as the director of pancreatic care for Nationwide Children's Pancreas and Liver Care Center, as well as the medical director for the TPIAT program at Nationwide Children's Hospital. Come up, Jay.
Thank you so much for having me, Megan. It's great to see you again. I miss you.
I know. We miss you.
It's a pretty good crowd for a Saturday. I won't sing, though, I promise. All right, I was asked to talk about the impact of these modulators on the liver. I know everybody wants me to come up here and show you all the data of how everything transforms on these medications, but I think the reality is the data we really have right now is more what is the negative impact. I'm not going to focus just on that for sure, and we'll talk a little bit about what data we do have, okay? These are my disclosures, none of which are pertinent. So my first objective is my soapbox, is to hash this idea that CFLD is not the term that we should be using. We have papers out that have now reclassified this. I'll get into it just a little bit, but we really need to start thinking about this as the hepatobiliary involvement. Then, of course, discuss the impact of these modulators on the liver in clinical trials versus real life, and then consider the use of modulators post-transplant or in those with advanced CFLD, and then answer the question, well, maybe, is the liver changing on highly effective modulators? So again, I like to show this all the time. The term CFLD was completely a bucket term used to anything for clinically insignificant elevation in transaminase levels to those patients that were dying and needed a transplant. Included in there is drug injury, as you can see. And so when you go back and look at the literature historically, it's so hard to compare things because you're talking about several different variations of a disease on a spectrum. And so we really need to get away from using that term. Like I said, we have two papers. We have the CF Foundation that came out with their screening guidelines. There are a few authors from that are also in this NASPGHAN and ESPGHAN possession paper that I was a part of as well, that really looks at making this a phenotypical description of what is going on to describe the spectrum of liver involvement. We do have this somewhat cumbersome, I admit, and again, I was a part of this work, but for any of the GI docs, you use the Paris classification, you classify your IBD patients. This is very similar to that and really gives you a better idea of what you're describing as opposed to just saying CF liver disease. And then I think probably the biggest thing is really using this term ACFLD or advanced CF liver disease when we are talking about that far end of the spectrum, nodular disease, advanced fibrosis, cirrhosis, and then portal hypertension, whether it's with or without cirrhosis. So really I want everybody to get into the habit of thinking about this as the spectrum and using this term CFHBI, okay? All right, off my soapbox now and back to what I'm supposed to be talking about. All right, so talking about the liver impact in clinical trials. So there's multiple trials. This is two. So on your left is patients with 2 delta Fs. The one on the right is with a single delta F, all over the age of 12. And what we see in the clinical trials is pretty low side effect profile when you think of it from a liver standpoint. Roughly 6% of those on ETI were having signs of elevated transaminase levels. And then if you actually look on the one on the left, they didn't even report, but if you dig through the data a little bit, you can see that for those that were on Teza-Iva, only about 2%, twice that to 4%, those that were on ETI. But I think there's these magical numbers of 3 times the upper level of normal and 5 times the upper level of normal. And that's because if you look at the warnings from Vertex, if you have 3 times the upper level of normal, that's when you first want to start thinking about whether you need to stop the dose or modify it if the bilirubin's also up. And then the hard cutoff is that 5 times the upper level of normal is where the advice is right now to stop these enzymes. Or I'm sorry, stop the ETI. I'm still thinking about the last talk. Thinking of things at a very high level is if you can go to liver tox, and if you're not a hepatologist or GI doc, this is an NIH database. You can take any drug, type it in, and it'll tell you sort of what the liver toxicity of it is. Now for modulators, they combine all of them together. You can't look at just ETI or Teza-Iva or whatever it might be. But basically they're saying roughly 25% of patients are going to have some degree of elevation of AST, ALT, and or GGT. But only 2 to 5% are going to be 3 times the upper level of normal with less than the 5 times. And they're usually self-limiting, no symptoms or anything like that. So at least for what's out there right now, this is a couple years old, only about 1 to 2% of subjects are requiring some type of dose adjustment or discontinuation, at least based off this. I really tried to focus this talk a little bit on one of the data that's come out the last year, because I kind of gave a similar talk last year, so I really want this to be an update, but I don't think we can forget this historical data. So this was a great study done several years ago in Colorado, and they looked at patients that were diagnosed by newborn screen, followed them for 21 years, and looked at how often they had an increase in their AST, ALT, or GGT. And the take-home point here is 95%, a little over, patients had at least one incidence of an elevated transaminase level. So for you to have an elevated transaminase level and have cystic fibrosis is like, yeah, you do. All right, so just having a mild elevation does not need to get us off medicine or get us super worried that this patient is developing liver failure or some type of horrible liver injury. So I think what's important is when we look at that data is to understand that in clinical trials, if you have liver disease, do they let you in a clinical trial? If anybody has elevated bilirubins, elevated transaminase levels, you're immediately excluded from those trials. And so sometimes we see that the real life data is very different than the clinical trial data. So is it? I don't know. So this is a slide I actually showed last year. I copied and pasted. And since that time, we now have at least 5 or 6 more papers that are all dedicated to the real life experience. So there's a ton of data that's coming out. If we look again at a very high level and look at the Vertex and CF Foundation data where they followed over 16,000 patients on ETI, mean follow-up at this time of almost 2 years, you can see that in this kind of lightish bar here, this is 3 times upper level of normal. The in between here is 5 times upper level of normal and 8 times the upper level of normal. Again, going back to the package insert, 8 times the upper level of normal, it says to stop drug and not reintroduce it. So that's why it's showing this, okay? And as you can see, this line here, I assume that's showing, right? Yeah. This is when we started medications. And what you really don't see is anything different. The degree of transaminase elevation really doesn't change when you look at the population level. Now, if you look at bilirubin, after starting medication, you do see a big jump. But remember, we have direct bilirubin and indirect bilirubin, and they're not equal. And we know that ETI and all of our modulators suppress OAT beta, which is a bile acid transporter that causes your indirect bilirubin to go up. I'm going to show some more data on that, but it basically creates a Gilbert's-like presentation and clinical implication. So looking at a couple of specific studies, this is from the group in Manchester, and they looked at a little over 250 adults who had been on ETI for 12 months. Kind of a larger group that had more advanced liver involvement at around 10%, 30% overall with some type of CFHBI. And because it was a European study, not surprisingly, about 36% of them were on Actigol or ursodeoxycholic acid. And so what they showed, and this is going to be a common trend, is if you look at the p-values all the way to the side, they're showing a significant difference, worsening, of ALT, AST, GGT, and bilirubin. But if you look at what those numbers are, we're talking about an ALT change from 20 to 26. That's normal to normal, right? Same thing in AST, GGT, and even for our bilirubins, really not too far off. So we really get into the idea with this data, are we talking about a statistical significance, or are we talking about a clinical significance? And I would say really what this data is showing us is that even though the numbers come out in a statistical formula as being something, you really don't see much difference. And if you look at those cutoffs of 3 times and 5 times the upper level of normal, it's a very small number of patients that actually reach that threshold. What I love about this paper is if we go a little bit further, and let's really focus on the ALT, as that's our more specific liver marker, and we look at those 8 patients that had significant elevation, you can actually blame this on something other than the drug in all but 2 cases. One had excessive alcohol use, stopped alcohol, liver enzymes went down. Basic hepatology, right? One had a viral illness, a couple had other medications that are known to cause drug injury, and then my favorite is the one that had the hepatic stone. So yeah, get rid of the stone. The liver enzymes got better. I can't really blame ETI for that one. All right? So it kind of gets you to this idea that, you know, it's pretty rare that we get to those elevations that are really from the drug. Looking at a pediatric experience out of Italy, this was 600 patients who were followed in their cohort. And again, if you look at that 3 to 5 times upper level of normal, you're seeing that the percentages of this is really quite low. So nothing much different there. And so I don't know anybody in this paper. I just thought it was a good figure, actually. So I mean this in a positive way. And they're not meaning it as clickbait, but this kind of feels like a clickbait paper to me, right? Because you have this idea of causing an increase in liver biochemical indices. So if you're in PubMed and you read that, you go, oh no, this drug is causing problems, right? But again, if you look at this change in bilirubin, total bilirubin, you're talking about a jump from 0.5 to 1. All right, and ALT from roughly 25 to 40. So maybe a little bit high. And they are showing that this was a little bit more pronounced on ETI compared to those that were on a Luma-IVA formulation, but you're still talking about numbers that are generally in a normal range. And then as I alluded to earlier, not all bilirubin is the same. We have several of these reports now showing that ETI, again, is going to cause an increase in your indirect bilirubin that probably has no clinical significance. Now, if you have an increase in your direct bilirubin, that is a completely different story. That is the lab that should get your attention. Even a change from 0.3 to 0.6, 0.8, numbers that shouldn't jump off the screen at you, that should get your attention more than a big jump in your indirect or an ALT of 60 or 70. One other thing that's come out pretty interesting, in my opinion, is this was a study out of Poland, but there's a couple that have come out now where they had 3 patients that had pretty significant elevation in their transaminase levels, mostly on ETI. One was on this clinical trial. And they were having transaminase levels, ALT, into the 200s. And they did a full workup, and they couldn't find anything, and they couldn't figure out what was going on. And so they had this kind of trend here where the dark line is the ALT and the dotted line is the AST. And they could figure out nothing as to why this patient was having elevated transaminase levels. So there is a way to use polyethylene glycol. Many of you know it as Miralax. But you can put it in a tube, and you can actually calculate a macro AST and ALT. Some of you have maybe heard of macroliposemia. But this is when these enzymes, they get bound to albumin or some other protein, and they actually just don't clear, and you can see these elevated levels, but when you actually can break it apart and fractionate it, you can see that the levels are actually 11, 37, 38 for ALT, and also normal for your AST. So this isn't going to be something common by any means, but if you do have somebody who's got really high elevation of their transaminase levels and you can't figure it out, this is something to consider. And then the last kind of in this area I want to talk about is we do have some data from the FDA. This is a very complex process. I'm not going to pretend like I fully understand it, but they basically take over 4.5 million reports of drug injury. And of those, they could break them down into 452 that they could attribute to ETI. So about 5% or 5.5%. And they're able to do these statistics over here that are in kind of the bottom right corner. I lost my cursor. And so for this PRR, ROR, this Bayesian marker, and this IC, any number that's over 1 and statistically significant tells you that there is an association with this drug with drug injury. So while I've given you a lot of data saying, these little bumps in liver enzymes don't get too worried about, there is real data showing that ETI does in fact have drug-induced liver injury. It's just in a small portion of patients. And we do know, and this is what I've been kind of talking about for a couple years now, is when we see these injuries, we're most likely going to see them early on in the process. So the mass majority are going to show this in the first month or so if they're going to have real drug injury. And we do have these case reports that we need to be mindful of. So this was one out of England as well for a patient who had actually been on ivacaftor for 7 months, developed a huge increase in their transaminase levels, got a biopsy, and this is what liver necrosis looks like. All of this disarray over here is necrotic liver. This patient was able to stop their ivacaftor, transaminase levels came down, but they're unable to restart. Similarly, we have this in an adult patient from Hopkins who had been on for about 5 or 6 months, developed a huge increase in their transaminase levels, again biopsied. This is again what necrosis looks like, but the trichrome down here, we don't see any fibrosis or anything looking at a chronic liver disease. If this was chronic liver disease, you should see little blue streaks everywhere, and you don't see that. Again, stopped ETI, they recovered, and the patient's doing fine off of medicine. So I don't want to be too cavalier and too dismissive because there are significant liver injury that can occur, but we just need to be mindful as to what the right markers are, and it's probably not AST and ALT, it's that direct bilirubin. So my message is to just have an approach. You can follow the Vertex guidelines, whatever it may be. I kind of make my living out of making the pulmonologist nervous and just letting things go a little bit. But as long as you have an algorithm that you're following and you're monitoring, I think that's the important thing. Quickly, there was a conversation in a session I was in earlier about using ETI in transplant. I showed a lot of the data last year. I'm not going to rehash it all, but I thought this was a great one that actually showed a 17-year-old who had a liver transplant at 11. They were actually listed to have a lung transplant. Their FEV went up, their BMI went up, and now they're no longer on the lung transplant list. So you can definitely use these medications successfully in your transplant patients. Here's some of the data that I actually shared last year. And the other one I wanted to talk about is I heard earlier somebody say that we shouldn't be starting ETI if we have severe advanced liver disease, including varices, and I would actually disagree with that. So this was a study out of the Netherlands where they looked at 7 patients who had very advanced liver involvement, including all of them with varices, splenomegaly. elevated transaminase levels, and they had this modified dosing where they started at step 1, which was just 1 tablet. You can see the dosing. I'm not going to read it to you, but it was a methodical way to get patients with advanced liver disease on ETI, and they were very successful. They even actually tracked levels of the 3 components to see where they were for an area under the curve to make sure that their drug metabolites were getting to a range that should be therapeutic. And I think this is the important part of this. All of them had improvement in respiratory symptoms. All of them had improvement in FEV1. All of them had an improvement in BMI, and they were able to either get to the 2nd, 3rd, or even the 4th step of the protocol, not even just the 1st step. So there is a way to get these patients on medication, even if they have advanced liver involvement. So is the liver getting better, which is what you want me to talk about? I don't know. I don't even know what we should measure, if I'm being completely frank. We have all these labs that I've talked to you about. We have ultrasounds, we have MRIs, we have liver biopsies. We have very little data for this. We do have this study out of Stanford that looked at LUMA-IVA versus ETI, AST, ALT, GGT platelets. They all actually did a little bit better on the LUMA-IVA. The lines for ETI are pretty stagnant, but they're still kind of from a normal to normal or a barely abnormal to normal. We're not talking about huge changes here. Similarly, when we look at elastography from one of the Italian groups, maybe those that had more advanced involvement, higher liver stiffness, maybe they improved a little bit, but really what you're seeing is lines that are pretty flat and again, stay normal to normal. Similarly, when we look at fibrosis scores in adults out of, again, the Manchester group, we don't see anything that's really different. There is a little statistically significant increase actually in APRI, but still not to levels that we think are really clinically important. So again, I think the data for ETI that we have is pretty stagnant and neutral. Don't see things getting a lot worse, don't see things getting a lot better. But the reality is this is a waiting game. We don't know. We can't answer this question. So this was a nice population study out of Ireland that I think is wonderful. In 2007, they looked at their patients that had advanced liver involvement, CFHBI basically, or no liver involvement. And they looked 10 years later and showed who changed into what category. Nobody from severe went backwards. Several patients from nothing went forward, or in between went to more advanced disease. And then you can actually see the mortality or transplant rates there at the bottom. So I think once we have national population data a few years out that actually shows us what these Kaplan-Meier curves really look like after we've been on drug for 5 years, I think maybe then we'll know really what the long-term impact is. So my summary is the negative impact of ETI and other modulators is minimal, but it's not zero. Assessing drug injury and liver response to modulators are more than just liver enzymes. It's really a combination of multiple markers and imaging, in my opinion. Modulators can be used effectively in patients with advanced liver disease and transplant. And unfortunately, I didn't answer your question. The long-term impact of modulators on liver is still to be determined. So I apologize about that. But I'm happy to take any questions. If I get off before she gets to the microphone. Okay.
Thank you for your presentation. I'll add GI fellow. When do you test and evaluate for further or other causes of liver disease in those who are on modulators? So you have someone who had normal baseline labs, started modulators, had some elevation in liver enzymes, and they meet HBI criteria. The guidelines did talk about further assessment, including the alpha-1 antitrypsin phenotyping and other causes. So do you have an approach to that?
Yeah, no, I mean, it's pretty common. If I'm going to do a workup, so if either their first time elevation is significant enough that it gets my attention or it persists for 6 months, they get a chronic hepatitis workup, so they get the full thing. I do get alpha-1. I just like to throw out there that alpha-1, has been shown to be a risk factor for the development of cirrhosis, not just in CF, but in alcoholic liver disease and other conditions. So that doesn't seem to be a CF-specific thing, but it's certainly worth getting. And there's absolutely no reason why you can't have CF and alpha-1 or, something else. So yes, I guess Dr. Narkowitz wrote this probably 10 years ago. We put it in our transplant paper, and now it's in the guidelines paper. These patients deserve a full workup.
With the even if we think it's just the modulators?
Yeah, I mean, I think getting simple blood work is simple, right?
Yeah.
I mean, and I think with the ultrasound and the elastography and stuff, these are things that are non-invasive that give us lots of information. I think one of the messages that push, and some of us that have been involved in this, what we know is that the data tells us when not to worry, right? We don't have cutoffs to say, now you have advanced liver disease. Here's the number, right? Or here's the change or the delta, even though that's what we rely on. But if all that stuff comes back normal, the ability to go to that family and say, look, your risk factor for advanced liver involvement is almost zero. We never say zero, right? But I think that peace of mind is what you're actually looking for when you're getting those labs and that workup. Not that you're necessarily trying to find something else. You don't want to miss it, but you're looking for that peace of mind.
Thank you.
Catherine Cutney from Case Western. I'm a peds endo. I'm struck by the fact that this story is very similar to the story with modulators and CFRD. For diabetes, we have the explanation that early pancreatic inflammation and fibrosis is fundamentally changing the beta cells. Can you think of a physiologic reason, like a similar explanation for why modulators aren't fixing CFLD?
Yeah, I think it goes back to the question, where's the CFTR protein? It's not on the hepatocytes, it's on the cholangiocytes, right? So are we actually looking at the right thing when we look at transaminase levels and these things? Some data has been presented and has been shown more out of Europe, showing changes in FGF19 and C4 that really are markers of the biliary system that suggest that maybe there's something going on there that's positive. But what that's actually doing as a reflection on our labs or anything else, we're not seeing. And then we've gotten up here for a few years now and said, hey, it's going to take 1 to 2 years for our outcomes. And now we're saying 3 to 5 years. And I think that's part of it is we don't know where that physiologic response really is occurring. And we don't necessarily understand what the downstream impact of it. I mean, even the other day, talking about what is the underlying pathophysiology of CF liver involvement. Well, it's probably not one thing. Right? And so that probably contributes to a little bit of the heterogeneity, the ambiguity of what we're testing.
Does this information change your thinking on what it is, right? Like it's obviously something that is sort of imprinted almost, right?
Yeah. So, I've been fortunate enough to be a part of the PUSH study for a little while. We presented some of the proteomics work, I guess a couple years ago now, that had a very strong complement and microvascular signal. Mike Knowles and the genetic modifier group just published this year their study of several thousand patients, and the genes, again, were a lot of inflammatory and microvascular. And then I've actually got some genetics work that they're pushing me to publish right now that I just haven't gotten to, that likewise. So I think there probably is more a microvascular component to this that we haven't fully understood. That's probably contributing to a lot of what we call CFHBI, and then what the impact of modulators is on that, I got no idea.
Thank you.
Hi, Lauren Lazar from UT Southwestern. Great talk, Jay. So you mentioned the PUSH study a few times, and you mentioned in your talk, we're not sure what, I guess, biomarkers to really be looking at in terms of ETI showing improvement in the liver. Do you think, based on data from the PUSH study showing imaging as being a big predictor of what will happen in the liver downstream, do you foresee imaging being, I guess, the biomarker of choice for improvement in liver or change in liver over time in terms of ETI's effects?
Yeah, that's a great question. The clinical application of PUSH is difficult, as we've always discussed. The research protocol, especially from the radiology standpoint, makes it somewhat difficult. I think, again, go back to my statement, if you have a normal liver, your chance of progressing is almost none. If you're in that heterogeneity, then it's a 9 times risk. So that just tells me I have to monitor. I don't know what the regression there is. I have a lot of data on FibroScan and transient elastography. I was a big proponent of this a couple years ago. Newsflash, unfortunately, the data doesn't look great. I'll probably get that out next year. So I don't know that that's it. Of the things that I'm seeing that I like the most, it's MRE. Because again, we still think this is maybe a little bit of a patchy disease. MRE gives you the full liver, which is nice, but you're not one to throw somebody through an MRI every year, and especially with our young kids. So I don't think we know yet. I think it's going to be part of the equation. And that's also kind of my other soapbox, is it's not one number, it's not one test, it's a combination of all of them and getting the trends together. That's probably what we have to be looking at. But to put that into a research protocol, that's exceedingly difficult.
Yeah, That makes sense. And yeah, MRE, I've always loved MR elastography as well. But we struggle a lot with, obviously there's children getting through an MR, but also the insurance piece of it. I don't know if you experienced that too.
This is going to sound horrible. Having written some of the guidelines and been a part of it, that helps me.
Yeah.
Because I just say, what's your name? And I'm going to put that in the chart that as the person who wrote this, that you're going to say we shouldn't do that. And so that helps a lot. But I also understand that not everybody can do that. So I'm really not that bad of a person, I promise, but it works for insurances.
I'll just tell them to call you. So sounds good. Thank you.
All right, thanks. Thanks
All right,
so much.
thanks, everyone.
We appreciate it.
Okay, so for our final speaker, we're happy to welcome Dr. Thomas Sfera. Dr. Thomas Sfera is the Chief of Pediatric Gastroenterology, Hepatology, and Nutrition at UH Rainbow Babies and Children's Hospital and Professor of Pediatrics at Case Western Reserve University in Cleveland, Ohio. He is the Martin and Betty Roskam Chair in Pediatric Gastroenterology and leads the gastroenterology component of the multidisciplinary care of patients within the UH Rainbow Babies and Children's Hospital Cystic Fibrosis Center. So thank you, Dr. Sfera.
Thank you, everyone. And I'm going to shift gears a little bit. We just had the full talk on liver disease. So now I'm going to talk about one specific component of it, and that's hepatic steatosis. Are we advancing? So my disclosures, I have no relationships that exist related to this presentation, but I do have other relationships that are listed here. So you heard about the categorization of liver disease in persons with cystic fibrosis. Here we have them listed here as Jay just went over them, and I'm going to be focusing specifically on hepatic steatosis. So hepatic steatosis in persons with cystic fibrosis, this is defined as the accumulation of fat within the hepatocyte. It's characteristically diffuse within the liver. Histologically, you see macrovesicular fat accumulation. Those are either single or very large fat droplets within cells. There's no inflammatory reaction, and there's no fibrotic changes. And you could see here on the slides, this is a normal image, and of course we did that. And you could see here is these white clear areas. During the processing, the fat is leached out of the tissue, and you see these big empty areas of fat accumulation within the liver. So I'm going to start with my key takeaway point is that hepatic steatosis, it may be present in the patient with persons with cystic fibrosis with no liver enzyme elevations. The significance of the steatosis as a risk for advanced CFLD is not known, but it may be present in fibrotic and cirrhotic disease. So what do we know about the prevalence of hepatic steatosis in persons with cystic fibrosis? It's actually quite common. There's a series of papers here listed, and it ranged from anywhere in 7% up to 36% of patients. And in this one study in 2019 by Bader, in 27% of patients without evidence of any liver disease, they had steatosis when they were specifically looked at when the whole population was screened. So you could see there's a wide range of variability in the reported prevalence of hepatic steatosis. This is likely due to the patient selection or these retrospective studies, who's getting these analyses done, and the type of evaluation is being done for steatosis. And we'll talk about the ways we can evaluate for it. And it frequently presents with no other evidence of liver disease. So what are the etiologies of steatosis? One, it could be innate to cystic fibrosis itself. Is it part of the spectrum of the disease, or is it secondary to other things such as nutrition? And there's evidence that it may be malnutrition, essential fatty acid deficiency, carnitine deficiency and choline deficiency, or it could be drug-induced or toxins. Steroids do this, and so does alcohol. And then persons of higher weight are known to have increased steatosis. So let's look at malnutrition. Early studies really suggested that malnutrition was a direct cause of steatosis. However, more recent studies, and here I have one from 2019, showed that it perhaps is not due to malnutrition. And here, hepatic steatosis in this study was not related to malnutrition as measured by the BMI, triceps fold thickness, or mid-arm circumference. How about essential fatty acid deficiency? In an earlier paper from 1990, you could see where linoleic acid was measured, and then across the x-axis, you see steatosis. Either it's absent, was present, and how severe. That if you have a essential fatty acid deficiency, the steatosis was found to be more severe in these patients. Then there are a few case reports of carnitine deficiency and choline deficiency, but again, these are all specific secondary causes. So you do have the exacerbating causes, which I also described. So let's turn and look at how could it be, what is it innate to cystic fibrosis? So we've seen earlier in the talks about the pathophysiology of disease within cystic fibrosis. We know this. This is a classic description of what occurs within the liver, where you have the CFTRs present on the cholangiocytes. You have impaired secretory function of these cells. You have decreased bile flow, thickened inspissated secretions, bile duct obstruction. You get liver injury, and that leads to fibrosis and cirrhosis. It doesn't lead to steatosis. So how do we get steatosis as part of being innate to cystic fibrosis? Well, we believe now it is a combination of dysregulated nutrition, and it's likely due to the intestinal inflammation and alteration in the intestinal microbiome. So you have intestinal dysbiosis. The combination of these leads to hepatic steatosis. So how do we identify hepatic steatosis? So the most common way, and it's likely found on the now recommended screening liver ultrasound, and you'll see it's described as a homogeneously echogenic liver. We have in panels listed as A as normal, and then the steatosis goes through. You can see there's abnormalities that they will see, and the radiologist will report these out. But that's not the best way. That gives you the indication that steatosis exists. It's not the best way to diagnose this or to follow it. There are several different ways to do it. One is using transient elastography. This is an ultrasound-based technique. It's a measurement of fibrosis and liver fat and liver fat content. And then we mentioned magnetic resonance imaging and elastography. This also measures the fat content. And then, of course, liver biopsy can do that. But when we look at these, there's advantages and disadvantages to each of these measurements. In transient elastography, you could do this within your clinic, in outpatient clinic, painless, inexpensive, can be reproducible, and you could follow this. If you were going to do longitudinal monitoring, it would be easiest to do because it's easy to do right in the clinic. Magnetic resonance elastography and imaging, it requires a visit to the radiology, can be uncomfortable for patients to actually go within the magnet, may require sedation. It is expensive, but it is reproducible, and it can be used for your longitudinal monitoring. Liver biopsy, though, again, you have to go to a procedure. It can be uncomfortable, expensive, may require sedation, and it's really not useful to monitor patients that way longitudinally for the degree of steatosis. So what do we have for treatment for hepatic steatosis? The one we have to consider is therapy may not be needed, as steatosis is often benign. But do we have this concern that it's going to progress? But I think some of our concerns, if there's other risk factors, it can. There's no specific therapy for reducing steatosis, although we do recommend optimizing the nutritional status, correction of essential fatty acid status, and consideration for supplementation, control of the diabetes, and also avoidance of steroids and alcohol. And we're predicting in the future that manipulation of the microbiome may be helpful. So again, we heard from Jay extensively how CFTR modulators work for liver disease in general, but in steatosis, again, the effect of CFTR modulatory therapy on steatosis is not completely understood because most studies for drug efficacy excluded these individuals with steatosis. There is some evidence that modulators can improve liver cholesterol metabolism, and there are a few case reports of improvement of steatosis, and I had a series of slides just showing these case reports, but again, they were just individual case reports or small clinical series. In fact, in our group, Dr. Cutney, who asked a question earlier, had a MR study looking at steatosis in patients that showed that they did reduce off of modulators. However, now in the Promise study, Dr. Narkowitz and the group, now poster 599, came up that ETI use for up to 3 years did not lead to any detectable improvement in steatosis in patients with in the normal population of patients with liver disease. So I think we still not sure how even the modulators are going to affect steatosis or what we need to be concerned with that. So what we know is that, again, it's common in persons with cystic fibrosis, and it's likely innate to the disease. But does improved care and the widespread use of highly effective modulators increase the possibility now of obesity-related hepatic steatosis? As our patients are gaining weight, becoming healthier, are we getting into a whole different realm that may be additive on top of this? And so we'll just shift a little bit to describe what obesity-related hepatosteatosis. This is also new naming conventions that have changed. We used to call it fatty liver disease or NAFTL. It's now metabolic dysfunction-associated steatotic liver disease. Again, the previous description of it results from overnutrition with adipose tissue mishandling of the excess fatty acids. There's also MASH, which is metabolic dysfunction-associated steatohepatitis. This was previously known as NASH, and this is inflammatory response to the increase in hepatic fat and resultant fibrosis and leads to cirrhosis. So here's the pattern that it goes from, the healthy liver over to where you have just a steatosis that is reversible, but you move on to MASH, which the inflammatory process and fibrosis, and this could lead to steatosis. So is this something that we need to be concerned with in someone who already has steatosis? Can they be a trigger as we're gaining more weight? Because again, we're seeing an increased prevalence of higher weight in persons with cystic fibrosis. CFTR modulator therapy is associated with increases in weight and BMI in CF. And again, hepatic steatosis in persons with CF is associated with a higher body mass index. So we do know that. And again, this is the slide showing that the nutritional status in our patients over the years. Now in the most current year, we have more increased incidence of obesity in overweight patients. So what are our nutritional considerations for a new era? Now in CF, this is the position paper in 2023, that people with CF are living longer, particularly with the advent of highly effective modulator therapy. The traditional high-fat, high-calorie CF diet may have negative nutritional and cardiovascular consequences as patients age, as persons with CF age. So what do we need to do to prevent the hepatic steatosis? Healthy diet and appropriate caloric intake, perhaps no longer, if you're doing well, and perhaps now pancreatic sufficient, no longer to say, eat as much bacon as you can, keep those candy bars in your pockets, and here's some snacks that we have on the way out the door from clinic. So we have to perhaps eat better, exercise. I think our patients are feeling better, right? Great lung function. Let's get them out there exercising. Let's change this. This is going to be helpful. Medications for weight loss. We have approved drugs in pediatrics. The ephedramine and topiramate are approved for pediatrics and in adults to help with weight loss. And then we all know about hear about GLP-1 receptor agonists, very common now, that are being used for weight loss. And then perhaps bariatric surgery for other adults. It's not really looked at in CF right now, but these are options, different types of therapies to help patients with weight loss. So let's just briefly talk a little bit about the GLP-1 receptor agonists in CF. And again, I'm not an endocrinologist, but their reported use in pancreatic insufficient CF with CFRD, and it's been shown to augment glucose-dependent insulin secretion in pancreatic insufficient CF. And use for weight loss has not been thoroughly studied. And there has been a few reports, and there's several posters now that are looking at it during the poster sessions that are looking at this for CF-related diabetes, and then helping with that, and then it's showing that there is some positive in weight loss. So, but what do we all have to know as more and more GLP-1 receptor agonists are being used? We have to be worried about there are side effects of acute pancreatitis. That's really going to confuse things in our patients. There is delayed gastric emptying that may worsen gastroesophageal reflux, nausea, and vomiting. They do develop gallbladder and biliary disease on these agonists. So in summary, hepatic steatosis is common in persons with cystic fibrosis. The steatosis is uncommonly caused by underlying nutritional deficiencies. Hepatic steatosis innate to CF does not characteristically progress to inflammation or fibrosis, but there's an increasing prevalence of higher weight in persons with CF, and this raises a concern for the development of masto and MASH. And that's it. Questions? Everyone's right on the clock.
Do we have any questions out there? I do have 2 questions. Give me a second.
And Dr. Safara, do you have any standard practice in terms of checking essential fatty acids in a patient who, maybe strictly has hepatic steatosis on imaging?
Yeah, that's it. I don't specifically. I think we should look at that again if they're healthy. I don't know if anyone really looks at that. I think they're healthy and otherwise growing. Nobody really checks for that. No, not necessarily. But I do think we going on DHA or any of the supplements, it's not going to hurt. Just see if you have any improvement with that.
So early on in your talk, you mentioned that steatosis may be present in fibrotic and cirrhosis disease, but stated that it does not likely progress to advanced liver disease. Can you reconcile those 2 statements?
Right. So there are, other causes of the liver disease in CF patients. And so it's not surprising that we could see patients who have progressive liver disease and then going along with that liver disease, there's steatosis, or there's other causes of the steatosis that's in there. But if you have a younger patient without other evidence of liver disease and they just have the steatosis, again, it's very unclear and it does not look like that progresses. So we'll get called as a gastroenterologist a lot when someone will have a patient with hepatomegaly and steatosis and it looks like what should we do? And it's really just watching those patients, making sure they're doing well.
Hi, thank you for your talk. Any experience with using the GLP-1 agonist in a liver transplant patient who has a CF liver transplant patient who has new onset diabetes after transplant?
I don't have that. Jay, any?
Thank you.
Yeah. Good question. No, yeah.
All right. I think
right,
that's
thank
it
you.
then. Thanks so much, everyone.
Okay.